speaker today is Dr. Madelyn Rosenthal. Maddie was born and raised in Fort Worth, Texas. She received a degree in art history from the University of Virginia. Although she loved art theory, she decided to pursue a career in medicine and attended Columbia University for a post-baccalaureate pre-medical program. She attended St. George's University School of Medicine prior to returning to her roots in Texas. Maddie completed her internal medicine residency and pulmonary fellowship at the McGovern School of Medicine, University of Texas in Houston. She then moved to Columbus for her final year of postgraduate training in sleep medicine. Maddie decided to remain a Buckeye and joined as faculty of the Division of Pulmonary, Critical Care, and Sleep Medicine. Currently, she works in the outpatient pulmonary and sleep clinics with a particular focus in chronic obstructive pulmonary disease, sleep disorders in cardiac patients, and home use of non-invasive ventilation. She is also the co-director of the James Pulmonary Rehabilitation Program with Phil Diaz. And take it away, Dr. Rosenthal.
Okay, so hello to everyone. Let me get my screen sharing and hopefully this will work as we had it set up and y'all can hear me. So again, thank you all for joining in today as listening to me as one of our wellness speakers. And hopefully some of this will be applicable to you while you are stuck at home and might improve your sleep at home, but also help your sleep when you get back to our regular schedules post-quarantine life. I have no disclosures or conflicts of interest for this presentation. During my talk today, we are going to take a focus on why we sleep and what makes us normal sleep. We're going to spend quite a bit of time discussing the sleep-wake timing and the two-process model or our internal clock, as well as the light's role in the sleep-wake schedule. We'll briefly talk about shift work as well as different treatment methods, and then move on to melatonin, which is another circadian phase modifier. We'll look at the effects of sleep or temperature on sleep, as well as the role of exercise in sleep quality. And then a couple of areas which we all need to know a little bit about, the effects of caffeine in sleep and how does alcohol affect sleep. I could have talked about many different areas in this topic. I just decided to focus on a few different things which I think will be applicable to most of the audience, as well as areas where I tend to get a lot of questions from my patients or even just friends and family. So before I start, one thing, if you do see the picture of me, no, I'm not sitting in front of a mountain. I just decided to be clever and try and use a virtual background so y'all didn't have to look at my boring office wall. So what is sleep? According to Merriam-Webster, it's the natural, easily reversible, periodic state of many living things that is marked by the absence of wakefulness and by the loss of consciousness of one's surroundings. It's accompanied by a typical body posture, such as lying down with the eyes closed, the occurrence of dreaming, and changes in brain activity and physical functioning. It's made up of cycles of non-REM sleep and REM sleep, and is usually considered essential to the restoration and recovery of vital bodily and mental functions. Just looking at a little graphic that I made, this gives us a little background into what occurs when we sleep. The comprehensive theory on the functions of sleep still remains elusive. However, what we do know is that sleep is central to the development and optimal operation of the brain. It helps with neural growth, processing and maturation, neuronal synaptic plasticity, learning and memory consolidation. Other functions include restoration and somatic growth, regulation of body temperature, energy conservation, removal of metabolic toxins generated during wakefulness, as well as protective and adaptive behavior and the immune defense. Briefly, what is our normal sleep? Well, it's divided into non-REM or non-rapid eye movement and rapid eye movement or REM sleep, which occurs in cycles. We typically have 3 to 5 of these cycles per night, alternating between NREM and REM sleep. Now, non-REM sleep is made up of stage 1, stage 2, and stage 3 sleep, which is what we consider our slow wave or deep sleep. And stage 3 sleep is the result of our homeostatic process and drive to sleep, which I'll discuss a little bit more about in a minute. So below, you'll just see this is a representation of a hypnogram. So if you have ever looked at one of the sleep studies, these are generated in all of the patient sleep studies and show us the patient's patterns of their sleep cycles. Typically, we will start going from wake down into stage N1 sleep, then N3. You usually will go into N2 sleep before going into REM sleep. And as you can see, as the night progresses, we see an increase in the duration of REM sleep in each cycle. Now, how many hours should we sleep? Well, of course, we hear, all the time, you're not sleeping 8 hours, you're not getting enough sleep. And if you sleep less, this is detrimental to your health. Well, current evidence supports that the general recommendation for obtaining it should be about 7 or more hours of sleep per night. And this will promote optimal health in patients from the ages of 18 to 60. Now, of course, there in the graphic that's on the screen by the National Sleep Foundation, there is kind of a wide range for each age category for how many hours you can sleep or what is recommended. But for most of us, you can see that any sleep less than 6 hours is going to be more detrimental to our health. So how does our body know how to sleep, know when to sleep? There's a 2-process model which was developed, which hypothesized that there's 2 innate processes that are kind of working synergistically to tell our bodies when to sleep. The first process is the sleep drive, or process S. And this is the result of adenosine accumulation during wakefulness. And this causes kind of a steady increase in the sleep drive. On the other hand, we have the wake drive, or process C. And this is the circadian rhythm of our bodies. It's our endogenous biological rhythm, or master clock, which combats the sleep drive to promote wake during the non-sleep periods. It is inherent and self-sustained, meaning that it is constant under external conditions. Looking at this graphic and closer at the 2-process model showing us our drive to sleep, as you can see, as the day progresses, starting at 7 a.m., we can see an increase in the homeostatic sleep drive as a result of adenosine accumulation. The green line represents the circadian drive for arousal. So you have a competition between both the homeostatic sleep drive as well as the circadian drive. Now, both of these remain in phase for a majority of the day. However, once the circadian drive for arousal hits its peak and starts to decline, then the homeostatic sleep drive takes over. And when you get to the nadir of the circadian drive with the peak of the homeostatic drive, this is what we call our sleep gate. And this is your body's greatest chance of being able to fall asleep. And it's the time when you tend to feel most tired and you're most likely to actually fall asleep. And then the process will recur the following day. So when you have, when you're sleeping, the levels of adenosine are going to gradually decline. And when those decline to their nadir, as well as you start having an increase in your circadian drive for arousal, that is one of the reasons that you will wake up. Looking at the another representation of the circadian wakefulness drive as opposed to the sleep pressure. So the sleep pressure you can think of also similar to the accumulation of adenosine. And so as the day progresses from 9 a.m., you can see that the sleep pressure goes up, as I just discussed before. Additionally, you're going to have an increase in the circadian drive for wakefulness. Now, what I tried to represent a little bit, but it's kind of difficult to do with arrows on PowerPoint, is that around 3 p.m., we tend to have a little blip or a little dip in our circadian drive for wakefulness. And with that, we tend to see a decrease in our alertness. So typically this will occur between 6 to 7 hours prior to your what we call your dim light melatonin onset, or which is the peak of your melatonin levels. That's when you'll have this kind of alertness level nadir. And then after that nadir, you'll have a little bit of a boost as the circadian drive for wakefulness starts to increase until it hits its peak. And then once it hits its peak, as well as the sleep pressure overcomes the level of the circadian alertness drive, that's when you really will start to see a precipitous decline in your alertness ability. I'll explain a bit more why this becomes important, particularly in different types of shift workers. Why am I talking all about this circadian rhythm? Well, it's important to understand that the circadian rhythm, or the endogenous biological rhythm, repeats about every 24 hours. And it has been found, however, that although we think that it is close to 24 hours, that the average person, the average human being's circadian rhythm actually is about 24.2 hours. And what this does, if we did not have any external clues, what we would do is slowly our internal clock would drift us later and later and later every day. So how do we change the clock? Well, the circadian clock, the central circadian clock, is located in the suprachiasmatic nucleus. And it is entrained to this 24-hour day, meaning that going from, instead of being 24.2 hours into a 24-hour day, it gets adjusted to this based on what we call Zeitgebers. And I really love this word because it originates from the German word Zeit and Geber, which when you translate those, it actually means the giver of time, which I just think is very neat because it's exactly what this is doing. These Zeitgebers are providing us with information exactly on what our external world is. The most important Zeitgeber, or driver, for our circadian rhythm is the light-dark cycle. And I'm sure y'all have heard a lot about blue light and blue light technology, which we'll talk about later. But blue light, with the wavelength of approximately 480 nanometers, has the strongest effect on our circadian rhythm. In addition to light, as well as the controllers for the central circadian rhythm, we have multiple other factors that can affect it. So you could have activity, the timing of food, the temperature of the day, and then just different social clues. So, you know, whether you have to stay somewhere for work, or, you know, whatever extrinsic factors other than light, which help you adjust your time, telling you when to go to bed, those could be considered in some cases to be environmental factors influencing the circadian clock. Now, in addition to the central circadian clock, we also have found that we have peripheral clocks in many organs around our body, including the pancreas, liver, adipose tissue, the heart, the GI tract, the muscle, white blood cells, the kidney, and the breast. And these receive stimulus both from the central clock, but it also can provide feedback to the central clock. How do we know what phase or what is our body's circadian rhythm? What is our body doing, telling us when we go to sleep? So there's two markers of the circadian rhythm. There is the DILMO, or the dim light melatonin onset, as well as we look at the core body temperature minimum. So the endogenous melatonin rhythm is really believed to accurately represent the timing of the central circadian clock, as the secretion of melatonin from the pineal gland is controlled by the suprachiasmatic nucleus. Additionally, we have the core body temperature, which variations occur over more of a kind of, they follow a sinusoidal rhythm. And we have found that the temperature as well as the melatonin circadian rhythms remain synchronized primarily by the entraining effects of the light-dark cycles. So the DILMO typically occurs about 2.5 hours before habitual bedtime. So if you remember the previous graphic that I showed looking at alertness, when we started to have that decline in our alertness, it was around the time of your DILMO. The core body temperature min normally occurs 2 to 3 hours before our habitual wake time. And when I say habitual, this means not the time that you set your alarm for, but if you were able to sleep and wake without having to be woken up by alarms for work, what this time would be. This graphic is showing us what we call a light phase response curve, which is a mathematical function to help us predict what effect light treatment is likely to have on circadian timing. So you can imagine this being generated by a lab experiment where in the beginning, the first, say, week or so, you have a patient maintain an 8-hour sleep opportunity at home to kind of stabilize the circadian timing. At the end of the week, the patient then goes into the lab and will sit in front of a dim light. After about 30 minutes, and then again every 30 minutes, you can take a salivary sample of melatonin and do this typically up until your bedtime or even a little bit later than the habitual bedtime. Then the patient typically will sit in front of a light box for an hour before sleeping in the lab. Once the patient wakes up the next morning, they'll stay in the lab until later that afternoon and repeat the dim light saliva collection. This is repeated over and over again, and the baseline DILMO is then compared to the second post-light treatment DILMO. You can then plot this phase shift on the y-axis, and the positive numbers are going to mean a phase advance, meaning that you are going to bed at an earlier time, whereas a phase delay will be at a later time. And then the x-axis is going to represent the time relative to your baseline DILMO. So what this represents is the magnitude and direction of the response of the central clock to light. So as you can see, there is a non-linear duration response function for the effects of light on circadian setting or resetting. So it is key to note that evening light before bedtime in the first and then light in the early morning, which is during your habitual wake time, will phase advance you, meaning that if you expose yourself to too much bright light during your habitual bedtime, it's going to make it even harder for you to go to sleep, and you're going to be shifting your circadian rhythm even later. Whereas if you were to expose yourself to a lot of bright light when you're still normally sleeping, or your body wants to be sleeping, this is going to make you feel tired and want to go to sleep at an even earlier hour. So how can this light affect our sleep? Well, most nighttime sleeping individuals, which a lot of us are, should avoid or minimize evening light. As I represented in the phase response curve, you could see that if you have that evening light, what happens is it will delay your circadian rhythm. It'll delay your release of melatonin, which will drive you to sleep even later. So light after sunset as is will also exacerbate this natural tendency to drift further out of sync with the 24-hour day, meaning that it will make it even harder for you to stay with your the extrinsic clues trying to entrain your circadian rhythm. It has been found that although the kind of compact fluorescent and LED lights might be more energy efficient, they tend to put out even more blue light than the kind of old-fashioned incandescent light bulbs. And although any light can really suppress the secretion of melatonin, blue light at night really does this the most powerfully. So what I tend to try to recommend to people is that if you are able to, one, even wear some sort of sunglasses or something like that on your drive home when it's still bright outside, that could help decrease the effect on your circadian rhythm. But also setting dimming timers on your lights at home to prevent your light bulbs, even if it is a 100-watt light bulb putting out, say 1200 lumens, then you can have it be dim when you get home or at a certain point. So this will try to prevent that delay in your clock and prevent the drop in your release of melatonin. So how can we protect ourselves from blue light at night? I did say, about the sunglasses driving home. It has been shown that the, gray tinted lenses of most sunglasses might have a little bit of an effect, but it's not going to have as strong of an effect as a pure blue light blocker glasses. So there are blue light blocker glasses that you can buy that you can get from lots of different designers, or you can even get it put in prescription lenses now, and they can be quite expensive. Whereas you could also look into getting some of these really fancy orange lens blue blocker glasses for the bargain price of about $4 on Amazon. When you think about the light in your house also once you are asleep, so a lot of times people will keep a light on in the bathroom or have some form of night light. Well, those are typically, white lights, which will have some form of blue light in them. And again, that can suppress your endogenous release of melatonin. So it's been found that red lights, so if you use different types of night lights that have a red light bulb, this has the least power to shift your circadian rhythm. So this is just a picture of some little nightlight bulbs that plug in that you can use to try and decrease the amount of bright light. If you can, you try to avoid looking at any bright screens 2 to 3 hours before bed, whether that be a computer screen, a tablet, an iPad. If you have to use an electronic device at night, consider wearing a blue blocker glasses or switching the device to night mode. There have been studies that have shown that when you wear the blue blocker orange glasses, you can actually produce as much melatonin as if you were in dim light. So it really does not have any effect on the dim light. It is debatable currently still about the night modes. There have been some studies looking into whether or not when you put them in night mode, how much blue light is emitted. But there haven't been any, controlled trials really looking at specific devices. So you kind of just have to take it with a grain of salt. And if you really want to have control over it, get some orange blue blocker lenses. So one thing to think about when you are on call and you take a look at your phone at 1 a.m., when the brightness is all the way turned up, essentially you're doing what this guy is doing to himself. You're doing this to your brain. If you ever are trying to explain to patients why you should, decrease the amount of blue light, one of the ways that I try to describe it, if you picture the walking down a street at night and you look up in someone's window in an apartment building and they have the TV on, and you see all of the light that's kind of flashing on and off as the TV is changing. Well, essentially, when you're sitting in front of a screen, what's happening is that light is basically a strobe light going into your brain saying, I don't need to produce melatonin and you don't need to be sleepy. So it's as though your brain is in a dance club when you're watching TV at night. It's kind of the easy, funny way that a lot of patients tend to understand what I'm saying when I explain that to them, and might help them change their habits. So one of the reasons I focus so much on the circadian alignment is because not only because light exposure does have such a significant role on how our sleep quality is, but also because I wanted to focus a little bit on shift work. Since a majority of us at some point in our careers, or even now under this crisis, might have to be called into different work hours that we are not used to. About 20% of all employed adults are shift workers, and it's been shown that about 17.7 to 25.9% of all the workforce starts their shifts between 2 and 6:30 a.m. Nearly all shift workers, we really could consider them to be what we call alternating shift workers or rotating shift workers. And this is because the patients or us, we tend to, even if you're on night shift for a period of time, we revert back to our daytime habits when we are off work for those few days. So you can see here that the majority of patients or people in the workforce that do shift work are these early morning workers. And that is, the majority of us, we could be considered early morning workers. Whereas then you have kind of the same amount of patients or people in the world, sorry, I keep saying patients, doing evening, afternoon work or nighttime work. And then about 11.4% of the shift workers do this more rotating or alternating shift work. So when I talk about morning shift workers, this is a group of patients who tend to start working between 5 and 8 a.m. We do have a significant amount of people who do that, including ourselves. And what happens is that even if you have to start work at 6 or 7 in the morning, you may awaken before 5 a.m. And what happens is you might be on the road during the circadian trough. So if you recall, when we look at the wakefulness and the sleep pressure drive, as well as your alertness level, if you look at it about 5 a.m., you're still really at this nadir in your alertness level. When you combine this with the sleep deprivation that might occur, it tends to result in patients being very, very sleepy on the road. Another way you can look at it is looking at what we call sleep inertia. So sleep inertia refers to the cognitive performance impairment, feelings of disorientation, the grogginess, and tendency to want to return to sleep experienced immediately upon awakening. It competes with the circadian drive for wakefulness, and although it tends to dissipate quickly upon awakening, it might be stronger than your sleep drive for wakefulness, particularly if you are sleep deprived. You tend to have more sleep inertia. So if you looked at this graphical representation, early on, your circadian drive for wakefulness might be less than your sleep inertia. And again, this is something that we tend to call sleep drunkenness, or when patients are sort of in that sleep state imbalance in which their sleepiness is overpowering their state of arousal. And so this results in your neurobehavioral and neurocognitive functioning being dampened. It has been found that there is a way that we can try and improve your alertness even while you are sleeping, particularly in people who have to wake up early for work. something called dawn simulators, which are light boxes that are designed to be placed near the bed and set to start increasing the light in the 30 minutes prior to the usual wake time. This is an example of one that's by Philips. There's a lot of different kinds that are out there on the market today that you can sync to your phone, have lots of different types of even relaxation exercises to use before bed. They tend to, you can also tend to set them so they stay turned on for about the first 30 minutes or so of the habitual wake time. And what this does is you will be increasing your bright light exposure, and you'll be decreasing the amount of any residual melatonin release that could be present. And these dawn simulators have been shown to improve both mood as well as alertness, and they tend to be the most effective when it wakes patients kind of early, so then they open their eyes when the light is on, rather than they are awake and sitting there and then the device is turned on. And really that is just because most of the devices only have about 230 lux, which that brightness has not been shown to be as effective in improving alertness compared to other light boxes that we do recommend for light therapy to help with alertness as well as circadian phase shifting. Night shift workers, on the other hand, they tend to result in even more sleep loss compared to evening or slow rotating shift schedules. The sleep loss tends to accumulate over successive shifts and results in a buildup of the homeostatic sleep drive. So you have this accumulation of adenosine that kind of has this rollover effect, even if you have slept a few hours at that time. This sleep debt also that you tend to accumulate and the effects of the circadian misalignment tend to negatively affect both productivity and safety. So what are ways that we can improve alertness and sleep when we are on night shift? Well, one thing that has been found is that you can do micro napping. So napping for 10 or 15 minutes here and there tends to improve alertness and actually dampens your sleep debt by decreasing the amount of adenosine built up in your body. One study that was done by Seisler and his colleagues up at Harvard, they looked at using light therapy for shift workers and how it could be used to try and shift the circadian rhythm and help the patients have a better daytime sleep and improve their overall function. So what they did is they had two different groups, the treatment group and the control group. The treatment group was exposed to 7.5 hours of bright light. Now, this is 7,000 to 10,000 lux, so significantly more than the Somnio, the little light box that you can use to help you wake up in the morning. They used this for 4 consecutive nights in the lab, and then they scheduled complete darkness between 9 a.m. and 5 p.m. at home. Whereas the control group was just exposed to room light of only 150 lux, and then they were able to sleep ad libitum. And what they found was that the patients treated, they had a shift in their circadian rhythm by 9.6 hours, which was more aligned to their shift work. This improved their nocturnal alertness as well as cognitive performance, and they did sleep an average of 2 hours more during the day. Well, of course, those were lab settings. It's not something we can typically replicate in our real world life. You can't sit in front of a light box for 8 hours when you're on shift. So another group, Smith and his Eastman, they tried to see if maybe something that could be replicated in the real world could also have a similar effect. What this group did was they tried to simulate 3 night shift days. Then you had sort of a 4-day or a 2-day weekend, pardon me, and then 4 days back on. This was trying to simulate the regular shift work block schedules. During the work days, the subjects were exposed to brief pulses of light, and The light during this experiment was also similar in lux to the bright light that was used in the previous study. And in total, while they were on shift work, they had about 1.25 hours of the bright light during their shift. And then when they were on their way home, they were wearing sunglasses to try and dampen the response to the environment affecting their circadian shifting. And what they did find was that there was even though it wasn't as marked of a shift that was seen in the previous study, there still was a phase delay in the circadian rhythm by about 7.5 hours. And there was an improvement in both sleep duration as well as psychomotor performance. So it's possible that exposure to, periods of very bright light during your overnight shifts could actually help to phase delay you in order for you to get more on your shift work schedule. So just a few summary tips for night or alternating night shift workers. So in the first half of your shift, trying to get as much bright light as possible. So, standing under those bright halogen bulbs in the intensive care unit or whatever unit you're in the operating room. Whereas in the second half of the night, you really want to try and avoid bright light. When you are driving home, if you can, wear blue light blocker glasses, but even wearing regular sunglasses will help some. It's just not as effective. One thing that's also been considered is something that's called anchoring. And this is when you try to maintain at least 4 or 5 hours of your sleep schedule to be similar to the days when you're working that shift, as well as days when you're not working that shift. It's been shown that with those 4 to 5 hours staying the same, it has been easier for your circadian rhythm to be stabilized onto whichever shift that you're working currently. Now we're going to move in a different direction. We're going to talk about melatonin, which is a question that I get asked about all the time. Should I be using melatonin to help with my sleep? So as I stated earlier, it is released by the pineal gland, and it is in response to the removal of bright light. There's 2 melatonin receptors in the brain, melatonin 1 and melatonin 2, which both can help mediate circadian resetting. Like bright light, exogenous melatonin has also been shown to reset the circadian pacemaker based upon the biological timing of the administration. So now looking at a different phase response curve for melatonin, you can see that in comparison to the phase response curve to light, we don't have the magnitude in the response to the melatonin as we did with light. However, we do see that there still can be a phase advance with exogenous melatonin administered, in the late afternoon or early evening before your habitual bedtime, with the maximal phase advances occurring about 5 to 7 hours prior to your habitual bedtime. The phase delays will tend to occur a couple hours after your habitual bedtime. And it's important to note that the effects of the timing of your melatonin needs to be in a specific time period. So if you were to take melatonin, say at if you normally go to sleep around like 10 p.m. at night, and you are trying to move your bedtime to a later, to an earlier time, if you accidentally take the melatonin only a few hours or an hour before your bedtime, what's going to happen is, instead of you shifting your bedtime or your circadian rhythm to an earlier time, it might delay you even more. So it is important to really work on this with a physician if you are going to try and use melatonin as an adjunct to try and shift your schedule. Another thing to note with melatonin is that the effects have been seen with doses as low as 0.02 to 0.3 milligrams. When we compared both 0.5 milligrams and 3 milligrams, you did see the same maximal phase advances or delays seen with either dose. In fact, even with the higher doses, what can happen is that the levels of melatonin can remain elevated in the circulation for longer periods. And so you can have what's called a spillover effect, meaning that instead of phase advancing you might cause a phase delay because the levels remain so elevated in comparison to when you have what we call your DILMO, as well as your relationship to your core body temperature min. Additionally, if you have too high of a dose and you get to a super physiologic level, this might desensitize the brain to the melatonin receptors. Additionally, melatonin, since it is a supplement, it's not subject to pharmaceutical regulation. And so the purity and accuracy of doses in exogenous melatonin typically vary very greatly. And so if you are trying to choose which one to take, you might want to consider looking into a formulation from a manufacturer who participates in the U.S. Pharmacopoeia Verified Program for Dietary Supplements. That is a mouthful. So in short, literature does vary greatly, and we need large randomized controlled trials to say, should I be using melatonin to help me fall asleep? It has been shown that it can help with initiation of sleep onset, but it really remains unclear whether or not melatonin should just be used for insomnia. It can, as I showed you previously, be used as an adjunct to light therapy for circadian phase shifting, or say if you're going on a trip for jet lag. However, trying to just use it to get an overall improved sleep, I personally don't recommend it. But what I say to my patients is, if it is helping them fall asleep and they don't notice any of the residual effects during the day, or they don't notice any shifting in their sleep schedule, or they're not developing any insomnia complaints, then I think that it's okay for them to continue taking it. I did briefly say, about why we can use melatonin in shift work, and essentially it's similar to the discussion I had about using light, except again, it would have to be timed on your phase response curve accordingly. Moving on to another interesting topic is the role of temperature in sleep onset and maintenance. So if you have a bed partner, there's a lot of times where you may disagree upon the temperature of the bedroom, someone being hot, someone being cold. Well, now you might have some evidence on kind of what you should use temperature-wise for the bedroom to help you have the best sleep. There has been a lot of study looking at the effects of temperature on sleep onset as well as the circadian rhythm. As we know, there is a sinusoidal pattern to your body's core temperature, and we have found that sleep in both warm and cold environments can affect your circadian rhythm. So in a warm environment, this is, say, a temperature being 31 to 38 degrees Celsius, has been shown to increase wakefulness as well as it decreases both NREM and REM sleep. Whereas cold temperatures, and this is very, very cold temperatures of 21 degrees Celsius, tended to also cause more awakenings, and it showed a decrease in the time spent in stage 2 sleep, as well as a total decrease in the total sleep time. In regards to cold temperatures, there still is a lot of research that's going on as to the overall effects of cold temperature on your circadian rhythm and shifting that we still don't fully know the effects of really cold temperatures on your circadian rhythm. We do know that when ambient temperature is decreased during sleep, there is an increase in the slow wave sleep activity. Several studies have looked into ways that we can manipulate our core body temperature to try and help with sleep onset. One study that looked at passive body heating found that if you were to increase your temperature, this is your core body temperature, to about 40 to 43, I mean, not your, your core body temperature to 40 to 43 degrees Celsius for about 30 to 90 minutes, this allows for more heat loss to occur. So if you are able to increase your core body temperature and your peripheral temperature of your body to a similar level, then we tend to produce more rapid heat loss, and that tends to promote more sleepiness. So in addition to the sleepiness that's brought on in decreasing the sleep onset latency, there's also shown to be an increase in the slow wave sleep duration. So one remedy you could do to try and promote sleep onset would be taking an evening bath or shower to increase your body temperature. You could wear bed socks or even put hot water bottles, trying to target the extremities. And the reason we want to target the extremities is because this is the area where we most effectively will, lose heat, most rapidly lose heat. And so that'll allow our peripheral temperature to reach the core body temperature quicker. And it's that decline in your core body temperature that will promote your sleep onset. So in regards to your optimal bedroom temperature, it's typically recommended for it to be between 60 to 67 degrees Fahrenheit. And this is because with all of your bed sheets as well as bedclothes on, you want to make sure that the temperature in your ambient temperature, the environmental temperature, doesn't get too high. So actually a colder bedroom might be better than, more of a what we call warmer bedroom. Next, looking at exercise and sleep. It's been shown that intense exercise can also raise the core body temperature by greater than or equal to 2 degrees Celsius. And this will then result in vasodilation and sweating and a subsequent core body temperature decline. So again, that can promote your drive to sleep. The exercise in the evening has been shown to shorten sleep onset latency, increase your total sleep time as well as slow wave sleep, decrease the REM onset latency, and decrease REM sleep. The timing of exercise and sleep, so really this evidence, it remains conflicting because a lot of the studies that were done, they are done with either elite athletes or people who are in very, very good shape. And it's not really more with the healthy or unhealthy sedentary population. But what the majority of the studies have shown is that most people who exercise closer than 3 hours to bedtime tend to have more disrupted sleep as well as a delayed sleep onset. And it's possibly thought this could be due to the disruption in your core body temperature and your circadian rhythm. Again, it's also debated upon what type of exercise should be recommended to promote healthy sleep. Most of the studies have been on endurance or aerobic athletics, with very few exercises more doing powerlifting or strength training. One study that compared power trained athletes to endurance athletes did find that endurance athletes had more slow wave sleep as well as increased sleep duration and shorter sleep onset, but it was a very small study. And again, these were also pro trained athletes. Most studies have found that exercising greater than 1 hour tends to be more beneficial. If you work out for longer than 2 hours, sleep may be more disrupted, even if you feel very fatigued, and this is generally because of muscle soreness or discomfort when you are in certain sleep positions. One recent study that just came out did show that even low impact physical activities such as walking did have improvement in sleep quality, and particularly in subjective quality. I'm sorry if I'm going kind of fast through these last bits, but I just want to try and get through it all if I can. So caffeine, as we all know, caffeine tends to disrupt our ability to go to sleep. It is a adenosine receptor antagonist. So as I've said over and over again, the buildup of adenosine during the day is what promotes our drive to sleep. So caffeine counters that by binding to its receptors and preventing the adenosine to have its effect. The average cup of coffee contains about 50 to 150 milligrams of caffeine, and our maximum daily dose recommended is about 400 milligrams per day. The diagram on the right just shows how much caffeine there is in a lot of the different beverages that we tend to drink every day. When we think about caffeine, it's important to consider the half-life. So in most people, the half-life is 3.5 to 5 hours, but depending on your metabolism is metabolized by the cytochrome P450 system, this might be delayed or increase, and also if you're on various medications. One study has shown that about 90% of individuals tend to drink caffeine in the evening, and 68.5% of individuals consume caffeine in the evening all the way up until midnight. So recent studies have evaluated when you could have your last cup of coffee, and they did actually do the effects of 400 milligrams, so the maximum amount of caffeine you should really have in the day, and looked at the time before bedtime. Well, obviously drinking it at bedtime is probably not going to be helpful or conducive to your sleep because it's going to block the effects of adenosine. However, when you administer caffeine even 6 hours prior to bedtime, there was a reduction in sleep efficiency as well as increased wake after sleep onset. And we do need to look at more studies to figure out why this occurs. But just one thing to keep in mind, which I typically say to my patients, is try not to have caffeine after 2 p.m. Okay, so the last area, which is very brief, is about drinking alcohol and what this does on your sleep. So many of the studies looked at the different ranges of alcohol concentration and measured it by your breath concentration of alcohol. They looked at typical doses ranging from about 0.16 to 1 grams per kilogram, which is about 1 to 6 standard drinks. And then they measured the breath alcohol concentration or breath ethanol concentration. It was found that even at low doses of 0.16 grams per kilogram, which is about 1 drink, it's shown to reduce sleep latency, which is good. And that's one reason a lot of people want to drink it, is to help them fall asleep. However, it might increase sleep time, but it does tend to produce poorer sleep. And when we get to even higher doses, it tends to have even poorer sleep. Patients tend to have even poorer sleep. And this is because typically you'll have a rebound sort of wakefulness in the second half of the night after alcohol is completely metabolized. There's also been shown to have a dose-dependent suppression of REM sleep, particularly in the first half of the night. You might have rebound REM sleep in the second half of the night, and again, this is because of the elimination of ethanol. So just key points really is that even at low doses, sleep is disturbed. So patients who did a study in which were drinking in the late afternoon and then their ethanol concentration at night was 0, they still found to have disrupted sleep in the second half of the night. We don't fully understand the mechanism of why that occurs, and that's still under a point of research. Maybe people will want to volunteer to, get drunk in a sleep lab and see what happens to their sleep. Anyway, just quickly, the key points I wanted to point out is that there's 2 main processes for sleep: the homeostatic drive and circadian drive. The circadian clock is controlled primarily by light, but it's affected also by exercise, melatonin, food timing, social cues, and temperature. Avoidance of bright artificial light in the evening can help with sleep onset. Blue light emitted from electronics can delay your circadian clock and should be avoided 2 to 3 hours prior to bedtime. And the use of blue light blockers or night shift mode, if you must use electronics at night, should be used. And exogenous melatonin can be used sometimes with sleep onset, but only at low doses. You should try to keep your temperature in your bedroom between 60 and 67 degrees. You could potentially use warm baths, bed socks, or heated water bottles to try and initiate sleep onset. Exercise, even light walking, should be done 3 to 6 hours prior to the desired sleep onset and can help with sleep initiation. Caffeine should be avoided at least 6 hours prior to sleep initiation, and alcohol should not be used to help with sleep onset or maintenance. Now, I know that there are a lot of questions, and again, I'm sorry that I went over my time. Nicole, how do we do the questions portion?
Yes, so I will go through and just kind of read them out to you. If you could just discuss them a little bit. We had quite a few coming in. Let's see, we had a few different ones come in regarding Fitbits tracking sleep and different fitness trackers, how accurate those are.
So the way that I typically describe the response to that question is the Fitbits try to take a model off of what we use for actigraphy to measure your sleep. Now, what this does is they typically have some sort, and they all have different trademarked algorithms for how they track your sleep, but there is essentially a algorithm that combines this accelerometer as well as the measurements of your, pulse time to try and see if they can create a resemblance of what your sleep actually looks like. So when you look at the different sleep stages, we tend to have different physiologic responses at each sleep stage. So what the algorithms try to combine is the change in your physiologic variables that are available to be measured by that specific device, in addition to the accelerometer or different positioning device that it has in it that measures, your amount of movement. And with that, they use whatever algorithm that they've created to show you a response or what your sleep looks like. And there is very conflicting data as to whether or not Fitbits are representative of your actual sleep. One study that's currently, it's even pre-publication, it shows that no, they are not. There is currently still no comparison to, a home sleep test or in-lab sleep study to assess the overall quality of your sleep.
Great, thank you. A couple other people had asked about if I wake up in the middle of the night, I have trouble getting back to sleep. Do you have any suggestions for solutions to that? Yes.
So it is very common for people to wake up during the middle of the night and not be able to fall asleep, especially if you have, a anxiety-provoking job, which most of us do. Once we wake up, our brain tends to kind of run rampant. So if one of the biggest things is when you wake up during the night is try to avoid any bright light, blue light technology. That's one, because again, that'll disrupt your ability to fall back to sleep. Two, try to avoid looking at the clock. So we all should have, an alarm set when we should be waking up in the morning. What happens when we look at the clock in the middle of the night and we recognize what time it is, we start thinking about, oh, I only have, such and such amount of sleep left, it's not going to be enough. And once you start thinking about that, then your mind's going to start, kind of snowballing and, thinking of all these other things that are going on in your brain. So what we try to recommend is that you don't look at any clock, you don't look at any phone. And if you're laying in bed and you feel like it's been more than 20 minutes or so. And again, this is just by feeling, not looking at the clock. If you haven't been able to fall back asleep, the recommendation is to get out of bed. I know that sounds crazy because you're really tired, but it's to get out of bed and go to some other part of your house or your bedroom where it is, dim lighting and do something that is boring enough that it is going to not keep you up, that you want to do it all night long, but stimulating enough you're not going to fall asleep in the chair wherever you are doing it. Definitely avoid turning on the TV or looking at social media, looking at phones, things like that. Some people will fold laundry I tend to color in a coloring book. And then once you feel tired, you feel like you're going to fall back asleep, that's when you go back to bed. What this is called, it's called stimulus control. And it's essentially trying to retrain your body that your bed is for sleep and sleep only. And when you aren't able to go to sleep, to prevent yourself from laying in bed and ruminating, but get out of bed to another place where you can take your mind off of your inability to go to sleep.
Great. I know we're over time, so if people, and Dr. Rosenthal, you can hang around for a little bit, we can do a couple more questions. We had a handful of people ask about kind of stimuli and how does watching TV before bed affect your sleep, and also listening to like a podcast and different sounds affect your sleep.
So in regards to TV, that's where I was kind of talking about the effect of the blue light. So when you think of, TVs these days, it's very interesting because a lot of the new terminology for the strength of the brightness that's coming from TVs, they've even created a new term. It's called a nit, is the unit of the brightness that comes from new LED TV. I just learned about that last night. Anyway, because they felt that describing the luminance from a TV and how it goes around the room wasn't described well enough. Anyway, sorry, I digress. But what that light is doing when you're watching TV before bedtime is it is going to be suppressing the amount of melatonin that your body is going to release. So it is essentially going to be delaying your dim light melatonin onset. And so it's going to be further shifting your endogenous circadian rhythm, your internal clock later, meaning it's going to be pushing you further towards the endogenous clock of it being 24.2 hours rather than the 24 hours that society dictates our life to be around. So trying to avoid, if you have to watch TV or, use some technology in the evening time, watching it, in my talk, I said 2 to 3 hours before bedtime. A lot of times that's when we're just getting home from work, so that's not feasible. At least 30 minutes to an hour prior to your bedtime, try to avoid any technology. If you can't, try and use blue blockers to help you. Now, when it comes to different sounds that can help you sleep, we usually recommend there to be as quiet as possible. If you need some sort of sound, so to block out, noise if you live on a busy street or something like that, white noise. And when we say white noise, we don't usually mean the, rolling waves of the ocean or the babbling brook that you might, be able to get on an app, but rather the pure white noise, which is just a frequency that's been shown to block out ambient noise, but it doesn't have a stimulating effect on the brain. There are, different theories behind using other types of ambient noise, like the rolling waves, things like that, that if it doesn't stimulate any type of physiologic response in you, meaning that you don't sit there and count the number of waves, and it can just actually have a soothing effect, then it could be used. For podcasts, I typically do not recommend podcasts to patients because you might hear something that will then trigger your brain to become more alert or more active. And so I typically try to avoid that.
Okay, awesome. We had a bunch of questions on melatonin. Mm-hmm. They just were about how much, how do you figure out the dose that you would recommend, how far in advance you should take it before you go to sleep, and if you wake up feeling kind of groggy, were you taking it too early? Why would that be?
So so that's why I kind of briefly went over melatonin, but didn't go into it too much. I knew this would be a topic of discussion, but it is a very complex and complicated topic. Because typically, we do not, as sleep physicians, we really don't recommend it for sleep onset or sleep maintenance insomnia. we usually use melatonin only to try and shift our circadian rhythms. And one of the reasons being is that it has been shown that we know that since it's not regulated by the FDA, the amount that you're getting in a bottle or in a pill or in a droplet, whatever compound that you're using, might not be the amount that you think it is. And so it might be labeled that it is, say, 0.5 milligrams. However, the individual tablet might be, say, 1. I don't know. It's just not regulated. There are the companies that are verified by the U.S. pharmacopoeia of supplements that you should trust more because they do test the products. So if you want to use it to help with sleep onset, that is okay. I would recommend that you take it within 30 minutes when you're trying to go to sleep, because it can cause, decreased alertness and arousability. And the dosing, a lot of people think that it should be 5 to 10 milligrams, but no, it actually should be very low. It should be 0.5 milligrams or 3 milligrams really at the most. And the way that I typically recommend is that you start at the lowest dose possible, as you do for any other medication, and try and increase the dose based upon your response. The biggest thing why you might feel groggy the following day is that you've actually taken too much of the medication, or you also took it, too late in response to your habitual bedtime. And what that does is that it kind of caused a shifting in your circadian rhythm. So when you're trying to wake up, you're still in your circadian rhythm is still dampened. So you're still at your nadir of your circadian rhythm. So your alertness is going to be very low. And that's one reason you can feel groggy.
Great. Thank you so much. Well, we'll probably do one last question before we wrap up here. There were a few questions on taking a little power nap in the middle of the day. Mm-hmm. Do you recommend that, or will it affect your bedtime?
Yeah, so sometimes power naps can actually be effective. We just do not recommend that they're over, and this, to be honest, I can't remember off the top of my head the exact number, but I believe it is it's either 15 or 20 minutes as the highest amount of time that you should be sleeping. And I can look that up and send it to you, Nicole, and you can send it out if you would mm-hmm. like, about taking, a brief nap during the day to kind of reset your alertness.
Yes, that would be great. I'll send out a follow-up email, and I would love to include that in there. Well, thank you, Dr. Rosenthal. That was a great presentation with great information. And thank you, everyone, for attending today. I will be sending out a follow-up email with some information that Dr. Rosenthal said she was going to send, as well as an evaluation. If you guys could take just a couple minutes to fill it out to help us better our programs, we would greatly appreciate it. And have a great weekend, everybody.
Thank you.